So, intestinal obstruction is basically today's topic, and we're going to discuss about the classification first of all. If we talk about the classification of the intestinal obstruction, it can be a dynamic obstruction or it can be a dynamic obstruction. But particularly, what do you mean by dynamic obstruction and adynamic obstruction? In dynamic obstruction, actually, there is peristalsis, but the peristalsis is present, but there is mechanical obstruction, right? But in adynamic obstruction, actually, there's no peristalsis, but there is also no mechanical obstruction as well. So if we talk about the classification, you can see here adhesions they make up almost 45% of the intestinal obstruction. Obstructed hernia makes about 12%. Inflammatory condition makes about 15%. Fecal impaction is about 8%, and carcinoma, like malignancy, which leads to the formation of the stricture, they account for approximately 15% of the intestinal obstruction. Pseudo obstruction, they make about 5%, and miscellaneous is another group which makes about 5%. So initially I was talking about the dynamic obstructions and adynamic obstructions, and particularly if we talk about the dynamic obstructions, they can be classified into intraluminal obstruction, intramural obstruction, extramural obstructions, right? So if we talk about the intraluminal obstructions, that means that there is obstruction, particularly a mechanical obstruction in the lumen of the intestine, right? There's a fecal impaction, you can see here, actually the fecal impaction, or the foreign body, or maybe the bolus obstruction, which is because of the gallstones. They are basically in a group of the intraluminal obstructions. And if we talk about the intramural obstruction, so this group includes the malignancies, strictures, intussusceptions, and also volvulus as well. There's another group which is called an extramural. That means that the outside the wall of the intestine. So that can be because of the adhesions, or that can be because of band formations as well. So this was about the dynamic obstructions. And if we talk about the adynamic obstruction, so there can be a pseudo obstruction, which is also called as a paralytic ileus. And most of the time, whenever we are performing a surgery which is involving the abdomen or the intestine, like laparotomy. So after that particular the intestine, they are low in mobility, and they go some kind of ileus, which is called as paralytic ileus, and there can be a pseudo obstruction. So this classification includes adhesions, which make about 40%, obstructed hernia, inflammatory condition, fecal impaction, malignancies, which ultimately lead to the formation of the strictures, and also the pseudo obstructions. So the question is, what is the pathophysiology for the intestinal obstruction? So actually, there are a number of causes. I have already discussed about all the causes in the previous slide. But actually, what happens is when there is a mechanical obstruction, and obviously that will lead to the increase in the peristaltic activity. And if the obstruction is not relieved, and more of the peristalsis is coming up, then what happens that slowly and progressively the peristalsis ceases, and because of that, there is a venous impingement. First of all, the veins are affected, so that will lead to the increase in the capillary permeability, and after all, the arteria separae is also compromised. And that lead to the actually, whenever the peristalsis ceases, there's flaccid and paralyzed and dilated bowel, and this kind of the bowel that leads to or precipitate to the formation of the inflammation, because number of the cytokines and interleukins, they are released because of the increase in the capillary permeability. So that leads to you can see here cytokines which are being released, and the macrophages, they accumulate, and then they lead to the formation of the nitric oxide and reactive oxygen species, which are basically the free oxidative radicals. And all of these they actually start an inflammatory cascade as well. And there's also whenever the arterial supply is compromised, there's strangulation, and then ultimately it leads to the gangrene of the gut. So this is very much important to relieve the obstruction. Why the intestinal obstruction? That is basically a surgical emergency, and the patient presents to you with the four cardinal signs, which are particularly abdominal pain, which is severe colicky in nature, vomiting, persistent vomiting, and also the constipation and abdominal distension. And constipation can be, if there's a complete obstruction of the bowel, that will lead to absolute constipation, and if there is partial obstruction, that'll lead to the relative constipation, right? So relative constipation means the patient is passing the flatus but not passing the stool, and absolute constipation is like the patient isn't passing the flatus and the patient isn't passing the stool as well. So if we particularly talk about the pathophysiology, I have already discussed that whenever there is a mechanical obstruction or there is intraluminal, intramural, or extramural cause of that particular obstruction, that lead to the increase in the peristaltic activity. And proximal to the obstruction, there is a dilatation of the intestine. And what happens to the distal portion, actually, in the distal portion, the peristaltic activity is not reached, and the bowel can be normal, and then later on it is also it goes to the flaccid paralysis. But if we talk about the proximal segment of the bowel, what happened that there is increase in the peristaltic activity initially, and if the obstruction is not relieved, that peristalsis ceases. And obviously when the peristalsis ceases, there's a fluid collection, because there are a lot of secretions which are coming in the lumen of the intestine, which include the saliva, which is about 500 ml, pancreatic secretion, which are about 500 ml. So gastric secretions, which are likely about 1 liter. So almost there's 2,000 ml or 2 liter of the fluid which is not being transported forward, and it is basically pulled out proximal to the obstruction, and obviously that lead to the flaccid paralysis of the bowel, and also there would be the proximal portion would be dilated, and that will lead to the inflammation, and obviously there will be release of the number of the cytokines because of the increase in the capillary permeability. There are a lot of cytokines, interleukins, which are being released, and also the free oxidative radicals, which ultimately lead to the gut necrosis. And first of all, what happened that the venous drainage is impinged and compromised, and then the arterial supply is also compromised. And whenever there is ischemia of the gut, so that is particularly irreversible, and that can cause a severe persistent type of a pain to the patient, and you have to relieve the intestinal obstruction as soon as possible. So this was about the pathophysiology. Now we'll talk about the strangulation. So what do you mean by the strangulation? You can see here in this picture that whenever there can be a stricture, there can be adhesions, or there can be volvulus or intussusception, whatever the cause of the intestinal obstruction. But the most important thing is the gut should not be strangulated, because whenever there is a dilated loop of the bowel present, there's a chance of the strangulation. Like there can be a twisting of the gut, and that can basically, you can see here, this is a dilated portion, and you can see here a band which is actually strangulating the gut, and ultimately this strangulation will lead to the gangrene of the gut, and ultimately you have to resect that particular segment of the gut which is being damaged. So this was about the strangulation. Most of the time, the hernias, which are the cause of the extramural intestinal obstruction. So these hernias, actually most of the time, the hernia contains fat or mentum, or can sometimes contain the intestine. You can see here, this is a hernial sac which is coming out, and also it also contains the gut loop which is coming from the defect. You can see here, this is the defect in the abdominal wall, and from that defect, this is the loop of the intestine which is being herniated, right? So most of the time, whenever there's a hernia, there's a chance of strangulation, because this loop of the gut is coming out from that abnormal defect which is present in the intra-abdominal wall, and this can lead to the strangulation. So strangulation is a surgical emergency, whether the intestinal obstruction, whatever the cause it is, or the hernia is obstructed, you have to immediately open the abdomen and relieve the obstruction, because it can lead to the particularly it can lead to the gut gangrene and death, and then ultimately you have to resect that portion of the intestine. So that's why you have to relieve the strangulation and obstruction. You can see here in this picture, this is small intestine. You can see here, this is the abdominal wall, and this is the intestinal protrusion which is coming from the abnormal defect which is present in the intra-abdominal wall. And you can see here, this is the hole, or you can see the defect in the intra-abdominal wall. And if we talk about the clinical features of strangulation, there can be peritonitis basically. What happens that initially, the large bowel and the small bowels, particularly if we talk about the large bowel and the small bowel, they are all enclosed in a peritoneum. So what happens that whenever there is intestinal obstruction, and ultimately that'll lead to the strangulation, and there's a gangrene of the gut, so there is an inflammatory cascade as well. So a lot of macrophages and cytokines and interleukins, they're coming for the defense of the body. They're coming at that particular site. So what happens that lead to the diffuse peritonitis. You can see here, this is basically, you can see here, this is a gut dilated loop. These are the air fluid levels. So these air fluid levels indicate that initially the inflammation is not limited to a localized area. It is a generalized involvement of the peritoneum. So whenever the peritoneum is involved, that is called as peritonitis or peritonism. And the symptoms of the peritonitis include acute acute severe colicky pain, and this pain, such kind of the pain is severe, and it does not respond to opioids. There's a vomiting as well, and there's whenever you touch the abdomen of the patient, there's a lot of guarding of the abdominal musculature, and also there is a generalized tenderness all over the abdomen. So that can be, if there's a strangulation, that ultimately will lead to the peritonitis, which can be a generalized peritonitis, and also this term is also called as peritonism. There will be pain, and the pain is severe, excruciating kind of the pain, which is not even being relieved by the opioids, constant and severe pain, and the patient can present to you with a shock. Why the patient can present to you with a shock? Because whenever there's a peritonitis, the patient can actually have dehydration, because a lot of the fluid is contained proximal to the obstruction. So whenever there is intestinal obstruction, and then that lead to the formation of the strangulation, and ultimately that can lead to the shock. Why? Because there's a hypovolemia, there's a dehydration, and there's a fluid loss as well. So all of these things contribute to the condition of the shock. So there's a series. All of these things are not actually happening in a matter of couple of minutes, but actually this is a generalized phenomena. What happened there? Intestinal obstruction. If we do not relieve the obstruction, that lead to the inflammatory cascade, and whenever that inflammatory cascade is initiated, that involves actually the peritoneum, and when the peritoneum is involved, that lead to the generalized peritonitis. And then the generalized peritonitis leads to the sepsis, and ultimately there's a dehydration, fluid loss, hypokalemia, and all of these things contribute to the shock ultimately. And whenever shock is present, you have to think about the ischemia, because secondarily to ischemia, whenever there is arterial supplies compromised, venous supplies compromised, the patient can go into the shock. So this is something very important. There can be skin changes as well, because whenever there's mesenteric ischemia, that can also involve the skin ultimately as well, and there can be skin changes like erythema or purplish discoloration. There's another type of the obstruction which is called the closed loop obstruction. You can see here in this particular diagram, that means that there's obstruction at the two distinct points. One is a distal obstruction and one is a proximal obstruction, right? So this segment, which is running from proximal obstruction to the distal obstruction, this is actually dilated, and this causes a closed loop obstruction. In case of the closed loop obstruction, you can see here the proximal segment is also obstructed, the distal segment is also obstructed, and there's a midline in between the proximal and the distal obstruction. There's a small dilated portion of the gut which is present, so this is called as a closed loop obstruction. And you can see here proximal distension, impending strangulation, and you can see the distal distension and the distal obstruction as well. So in case of the closed loop obstruction, most of the time what happens that the cause is a carcinoma, and ultimately the carcinoma lead to the formation of the stricture. You can see here stricture is basically the narrowed part, or whenever there's a carcinoma, there's a malignancy. So that malignant tumor, there's a lot of extensive fibrosis, and ultimately that extensive fibrosis lead to the formation of the stricture. You can see here in this diagram. And particularly, this is the closed loop obstruction because there is a stricture here as well, and there's a stricture here as well. So what happens that proximal and the distal, there's a proximal and distal obstruction, or there's a stricture proximally and distally, and in between the portion is dilated. In case of the carcinomatous strictures, this is called as closed loop obstruction, right? You can see here carcinomatous stricture. Okay, so we talk about the mechanical intestinal obstruction, and we talk about the dynamic obstructions, because whenever there's a mechanical intestinal obstruction, that is called as a dynamic obstruction, right? So we talk about the dynamic obstruction, like which involves the intra-abdominal obstructions, which involves the intramural obstructions, and then the extramural obstructions. So if we talk about the extramural obstruction, this is the internal hernia. And this hernia is particularly the cause of the mechanical intestinal obstruction. And it is one of the extramural type of the obstruction, because actually this hernia is actually compressing. A pressure effect is generated just from the outside of the wall. There's no internal pathology of the intestine, or there's no malignant stricture or volvulus or intussusception, but there is the external pressure just from the outside of the intestinal wall. So that pressure will lead to the mechanical intestinal obstruction. You can see here in this picture that this is actually the hernial sac, and this is the whole of the gut loop which is coming out from the abdominal wall defect, and there's a small hole, and whenever the intestine is passing through that small hole, these are the abdominal wall musculature which is causing the pressure effects on this small constricted part. So because of this internal hernia, this is causing a mechanical obstruction which is extramural, which is developing a pressure symptoms just outside from the abdominal wall. So this is particularly important in case of the internal hernias. But if we talk about particularly about the hernias, the abdominal hernias like the epigastric hernias, incisional hernias, or even linguinal and the femoral hernias, most of them, they contains the loop of the intestine. So whenever the hernias containing the intestinal loop, the thing which is very much important is to identify the strangulation, because these strangulated hernias, they cause the intestinal obstruction. They can be partial obstruction, they can be complete obstruction. It depends upon the the gut segment which is coming out in that particular defect, right? So in case of these internal hernias, we need to rule out the element of obstruction or the element of the strangulation, because a hernia which is containing the bowel loops or omentum or fat, and these are particularly not obstructed or strangulated, the surgery can be delayed. There is no indication for the early surgery. But if the hernia is containing the gut loop and there's a mechanical obstruction, or there's a strangulation, right, or incarceration, that is a surgical emergency, and you have to perform the surgery immediately, as soon as possible. You have to relieve the obstruction so that the gut segment do not develop a lot of ischemia or irreversible ischemia, because whenever the gut will develop irreversible ischemia, ultimately it'll lead to the gangrene, and that gangrenous portion of the intestine that has to be resected, right? So to avoid all these complications, we need to figure it out whether the hernia is obstructed or strangulated, because we have to do the emergency surgical procedure, right? So this was about the internal hernias. You can see here, again, this is the hernial sac which is coming, but that's causing the obstruction as well. So it should be relieved as soon as possible. Okay, but most of the time, in case of the internal hernias, actually, these internal hernias may be coming from the foramen of Winslow, or the cause can be the defect in the mesentery. It can be because of the defect in the transverse mesocolon or the broad ligament. They can be congenital or acquired diaphragmatic hernias. They can be intrasigmoid and duodenal retroperitoneal fossa, or they can be cecal or appendiceal retroperitoneal fossa, right? So most of the time, these internal hernias, they're coming from the foramen of Winslow or defect in the mesentery, because these internal hernias are not actually involving the intra-abdominal wall, but these hernias are actually coming from all those the spaces within the peritoneum, like the foramen of Winslow. There can be a defect in the mesentery, there can be defect in the transverse mesocolon, there can be a defect in the broad ligament, there can be some congenital or acquired diaphragmatic hernias, there are a lot of retroperitoneal fossas which are located inside the peritoneum. So these internal hernias, they can be coming out from the retroperitoneal fossa, or they can be coming from the cecal or appendiceal retroperitoneal fossas. So they can be obstruction because of the enteric strictures, right? Most of the time, the strictures can be formed after the inflammation, right? So whenever there's enteritis, like in case of the gastroenteritis, and in case of the enteric perforation or enteric typhoid, most of the time there can be stricture formation. There can be TB as well, and there are a lot of other causes like the malignant. There can be malignant strictures, right? So you can see here, this is the stricture which is located here, and the proximal segment of the loop is so much dilated because of the impaction of the stool, and because of the fluid which is being not transported distally to the obstruction, right? So all of these things, these are very much important to keep in mind. So if we particularly talk about the enteric strictures, they can be after chronic, there is acute gastroenteritis, and that is not being resolved for a long time, so there can be stricture formation as well. There are some inflammatory bowel diseases like ulcerative colitis and Crohn disease, but most specifically the Crohn disease, there's a lot of stricture formation in the Crohn disease because it's a chronic inflammatory process, right? So whenever there's a chronic inflammatory process involving the gut segment, and that can lead to the formation of the strictures. And there can be a stricture formation in typhoid, there can be stricture formation in tuberculous infection as well, and there can be malignant strictures like the although malignant strictures are now very common, like the lymphoma, or the carcinomas or sarcomas, but there can be one of the cause of the strictures, although they're not very common. Most of the time the inflammatory pathology is very common behind the strictures, like I already talked about the typhoid, the typhoid or the tuberculosis, or the inflammatory chronic inflammatory diseases of the bowel, like the inflammatory bowel diseases, specifically Crohn disease. So these are particularly very important. Malignancies are not very common, but you have to keep in mind, like the lymphomas, carcinomas, and sarcomas, they can be cause of the enteric strictures. You can see here there's a blockage, and there is a site of the stricture. So I talk about that the chronic inflammatory diseases like the Crohn disease, inflammatory processes, chronic inflammatory processes involve the ulcerative colitis and the Crohn disease most specifically and most commonly. But there's not a lot of stricture formation in ulcerative colitis. So most of the time, this is the Crohn disease, which is involving the formation of the stricture. You can see here, this is the normal intestinal surface. In this diagram, there's a smooth contour. There's no raw surface in case of the intestine, but in the wall is also very much normal. But in case of the chronic diseases like the Crohn disease, you can see here there is a lot of raw surface of the intestine, and there's also formation of the stricture in case of that. And the intestinal surface is because of there's a lot of, in case of the chronic inflammatory processes, we know that there's a lot of fibrosis, right? So that fibrosis ultimately lead to the extensive fibrosis lead to the cobblestone appearance of the intestinal surface, and because of that fibrosis, extensive fibrosis, there is a formation of the stricture as well. You can see here there are also the formation of some fissures, and the wall of the intestine is not very smooth, and because of the extensive fibrosis, the thickening of the wall is also present. So there's another, if we talk about the dynamic obstruction, so there's another category which is called as a bolus obstruction, right? The bolus obstruction means that the obstruction is within the lumen of the intestine, and the cause can be, the bolus obstruction can be because of the gallstones, it can be because of the food, it can be because of trichobezoars or the phytobezoars, and it can be because of the stercolith and worms. We'll be discussing all of these things one by one. First of all, we talk about the gallstones. You know that the gallstones, they are formed in the gallbladder, and we know that there's a cystic duct which is coming from the gallbladder, and the cystic duct, there are a lot of, we know that the gallbladder is located at the posterior surface of the liver, posterior inferior surface of the liver. So what happens that there are a lot of hepatic sinusoids, and they combine, hepatic acini, they combine to form the right and left hepatic duct, and right and left hepatic duct actually combines to form the common hepatic duct. And the common hepatic duct and the cystic duct, which is coming from the gallbladder, they combine together and they form a common bile duct. And this common bile duct then ultimately drains into the duodenum at the major duodenal papilla, right, in the second part of the duodenum. So what happens that whenever there is a gallstone which is present in the gallbladder, it slips down from the cystic duct and comes into the common bile duct, and through the common bile duct it comes into the duodenum, right, in the second part of the duodenum. So sometimes what happens that this a stone is spilled from the second part of the duodenum, it comes all the way to the intestine, it can involve the duodenum or jejunum or ileum, but most commonly duodenum and jejunum are being involved, and they can lead to the obstruction within the luminal wall. So this is particularly called as a bolus obstruction or a gallstone obstruction. They can be because of food, some of the like undigested food. Most of the time they can cause the obstruction as well, because those particularly if we talk about the food that is undigested or that is not chewed in a very very effective way. So that unchewed or undigestible food, actually that is, there's stasis of food and that particular segment of the bowel, and that can lead to the intestinal obstruction as well. Now, if we talk about the trichobezoar and the phytobezoars, what happens is like trichobezoars is like there's a psychiatric illness, and in that particular psychiatric illness is more common in the females. And in that particular psychiatric illness, what happens is the patient actually eats up the hair, right? So these hair, they got trapped into the lumen of the intestine because hair cannot be digested. There are no particular enzymes which act on the particularly hair and they digest them. So they are actually undigested. And in that particular psychiatric disorder, particularly in the females, what happens is that the patient actually chews up the hair, and he is fond of eating the hair. And whenever they reach the lumen of the intestine, what happens is that particular condition is called the trichobezoar, and that lead to the formation of that lead to the intestinal obstruction, right? And there's another category which is called as a phytobezoar. And in phytobezoar, what happens that phyto means plants, right? So most of the time there is a lot of high fiber diet. So whenever a person is taking a lot of vegetables or vegetables and fruits, and there's a high fiber diet, so that high fiber diet which is not being churned up and chewed up, so that unchewed high fiber diet that comes into the intestinal lumen and that blocks the lumen of the intestine, that remains there. There's a stasis of the food, and that'll lead to the intestinal obstructions, right? So there's another category which is called stercolate. Basically, what happens when the undigested material that comes into the lumen of the the lumen, most of the time we know that there's a bile, and bile is particularly very much important for the digestion of the fats and fat emulsification, very much important. And if we talk about, we don't go to the details how the bile works, but actually the metabolites of the bile, they're urobilinogen or stercobilinogen, right? So what happens that in case of stercolate, what most of the time that stercobilin containing stercolate, that stone is formed, and that stone causes the intestinal obstruction, right? And in children, we know that worms, they are very much common, and in particularly the Ascaris lumbricoid. These are very much important organisms which can be found in the intestine. So actually what happened that these worms, when they're not excreted out and they stays in the lumen, they cause the intestinal obstruction. So this is all about the bolus obstruction, which is a separate entity, and it involves the obstruction because of the gallstone which is actually slipping from the common bile duct and coming to the duodenum, and then involving the jejunum or ileum, whatever the portion may be. And there is obstruction secondary to food, particularly the undigested, unchewed food. And there can be trichobezoars or the phytobezoars, which is because of the hair or because of the high fiber diet, the obstruction can be there. And there can be stercolate and the worms, and specifically if we talk about the worms, it is Ascaris lumbricoides, right? So there can be adhesions in the bands. Initially, I talk about that there are some kind of extra luminal causes. In the previous slide, we talk about like the gallstones and all these things. They are the bolus obstruction, that is basically the intraluminal cause of the obstruction, right? But particularly if we talk about the extramural causes, so the extramural causes include the adhesions and the bands, right? And adhesions are formed whenever there's a chronic inflammatory process, or after the extensive surgery, which is involving handling with the intestine, right? Whenever there's a handling with the intestine, initially there's a lot of fibrin deposition, and initially there's the adhesion, they're mainly composed of fibrin. But actually, with the passage of time, there's a fibrosis, and these fibrin adhesions, they are converted into particularly the fibrous adhesions, and then you have to break these adhesions surgically, right? So as we talk about the intra-abdominal adhesion causes, they can be foreign material, like most of the time, like there can be talc or suturing material, particularly silk. If you are using silk intra-abdominally, that can lead to the formation of the adhesions, right? And there can be acute inflammation. We know that whenever there is an acute inflammation or there's a chronic inflammatory process, all of these things can ultimately lead to the fibrin deposition, and with the passage of time, this fibrin adhesions, they can be converted into fibrous adhesion with extensive fibrosis in the undergoing process. So this can lead to the formation of the adhesions, right? There can be infections, particularly if we talk about the typhoid infections or gastroenteritis, because in case of the gastroenteritis, adhesions are formed as a result of the acute inflammatory process. There can be other chronic inflammatory conditions, like we talk about the TB. TB is also the chronic inflammatory process, and there can be some ulcerative colitis, Crohn disease. They can involve the formation of the intra-abdominal adhesions, and there can be radiation enteritis. So these are all most common causes for the adhesions, and whenever there are adhesions, actually they are formed in one segment of the the adhesions can be within the different segments of the intestine, or the adhesions can be between the different other peritoneal organs, like the adhesions can be with the other viscera, like the liver or spleen, or the pelvic cavity, particularly the urinary bladder. So we have to relieve all these adhesions in case of these, and you have to keep the causes of the adhesions in your mind, like the foreign material, acute inflammatory processes, chronic inflammatory conditions. There can be infections like the acute gastroenteritis, and there can be radiation enteritis as well, right? So there can be some preventive strategies for the adhesions and the band formation. You have to use the good surgical technique, and you have to be very careful, like whenever you're performing abdominal surgeries, you have to be very careful while using the suturing material, so that the good surgical technique is very much important. If you minimize the intestinal contact with the gauze, so that can be also a good preventive strategy for the formation of the adhesions and the bands. And also, if we wash the peritoneal cavity with the saline after the procedure is being completed, so this can be also very much helpful for the prevention, right? So and if we cover the anastomosis and the peritoneal surfaces, that can be also important in the prevention. So whenever we know that post-surgical adhesions, they're very much common. So in order, and we know that these adhesions and the band formation then lead to the intestinal obstruction. So if we want to avoid all these complications, we have to use a good surgical technique. We have to use a good surgical suturing material. We have to minimize the contact with the gauzes, and we have to do the peritoneal wash. It also, it has a dual advantage, it also minimizes the the formation of the adhesions in the bands, but it also minimizes the risk of the infection and the sepsis after post-operative infections and all that. And if we cover the anastomosis with a mesentery, or we cover the peritoneal surfaces, that can also lead to the prevention of the adhesions and the bands. So this was about the adhesions and the band prevention, and sometimes now most of the time laparoscopic techniques are being used. So one of the the recent research that also indicates that if we compare the laparoscopic technique with the open repair or open surgeries, there's a less chance of the formation of the adhesions in the band. So those people who are expert in the laparoscopic technique, they should use the laparoscopic techniques for the abdominal surgeries as compared to the open surgeries, because that minimizes the risk of the adhesion and the band formation. Particularly, there's another entity which are particularly called as bands. You can see here, this is a one segment of the intestine. This is the abdominal wall, and what happens that there is a band, fibrosing band, because whenever there is there's a acute inflammatory process, and whenever there's a process of healing, we know that healing involves the formation of the fibrous tissue. So what happens that actually whenever there's a healing of the wound, a fibrous strand is actually formed between the intestinal wall and the abdominal wall, from extending from the lumen of the wall and going down to the abdominal wall. So that can also lead to the formation of the bands, and these bands can be acquired or they can be congenital. And sometimes, like if we talk about the congenital bands, there can be obliterated VID, there can be string band following the bacterial peritonitis, and there can be adhesion of the greater omentum, which are basically adherent to the parotides. So there can be, if we talk about the bands, there can be congenital band formation and the acquired band formation. Acquired involves the different kinds of the inflammatory processes, particularly bacterial peritonitis, and in case of the congenital, there can be obliterated vitro-intestinal duct. So VID stands for vitro-intestinal duct. So if we talk about the congenital band formation, there can be obliterated vitro-intestinal duct, there can be band following the bacterial peritonitis, or there can be greater omentum which is being adherent to the parotides. So now we have to talk about the intraluminal causes of the obstruction, right? There can be some other intraluminal causes of the obstruction, which is called as acute intussusception. And let me tell you that these intussusceptions are very, very much common in the children. So what happens that in acute intussusception, this is one segment of the intestine, this is another segment of the intestine, and one segment of the intestine is pushed into the other segment of the intestine. A portion of the intestine goes into the other portion of the intestine. This is particularly called as intussusception, right? And intussusception is a very much common cause. And if a patient, if a child of 4 to 5 months is coming to you with severe abdominal pain, you have to think about the acute intestinal obstruction, because it is very much common in the children. You can see here, there's the proximal part, there's the distal part, and most of the time actually this is the proximal part which is going into the distal part. So this is the proximal segment, this is the distal segment of the intestine, and one portion of the intestine is going and protruding into the other portion of the intestine. And you can see here, this is most of the times the proximal part which is going into the distal part. So this is the proximal segment which is involving and going into the distal part. And there are 3 parts of this intussusception: the outer part, the middle part, and the internal part. So this is basically the middle part, this is the outer part, and this is the inner part, right? You can see here, this is the retention of the intestinal contents and the distended bowel, which is above the intussusception, and this is the part of the bowel which is being intussuscepted in the diagram. So if you talk about the parts, you can see here, there are 3 parts. One is the apex or the neck. Apex is particularly the part from which the intussusception is taking place, and neck is the part from where the apex and the middle part, the main portion of the bowel wall, which is going into the proximal segment, which is going into the distal segment, which is also called as intussusceptum. So neck is a portion which is joining the apex and the intussusceptum, and also there's another inner part which is called as intussusceptions, right? So these three parts, they're very much important if we talk about the the structure of the intussusception. There is the outer part, there's the inner part, and there's a middle part, and there's an apex. Apex is the point from which the segment is entering. The middle part is also called as intussusceptum, and the inner part, which is the intussusceptions, that is the most inner part of the intussusception. And you have to keep in mind that acute intussusceptions are very much common in the children. They can be also present in the adults, but most commonly in adults, the cause for the intestinal obstruction can be a volvulus, if we particularly talk about the intramural obstructions. But in case of the children, the cause of the acute intussusception in the children is most of the time obstruction is the acute intussusception, right? So you can see here and the diagram. So what are the clinical features of the acute intussusception? Again, the patient will present to you with the cardinal sign of the obstruction, that is abdominal pain, severe abdominal pain. Initially, the pain is very much colicky, but later on, if with the passage of time that is converted into dull ache pain, there is a vomiting, a lot of vomiting, and there is constipation as well. The obstruction can be, and there's an abdominal distension. So basically, the obstruction can involve the small bowel segment. The obstruction can involve the large bowel segment. If the small bowel is involved, the most prominent feature would be the most prominent feature would be vomiting. But if the large bowel is involved, the most prominent feature would be constipation. But if we talk about the high small bowel obstruction and high and low small bowel obstruction, and then the large bowel obstruction. So in case of the high small bowel obstruction, most of the time vomiting is very much common and cardinal feature. And in case of the low small bowel obstruction, abdominal distension is more pronounced and the pain is also more pronounced. And in large bowel obstruction, abdominal distension and constipation, these are more commonly involved. So you can guess from the signs and symptoms of the patient that the obstruction is involving the small bowel or the large bowel, and there can be partial obstruction as well. Sometimes there can be, the symptoms, the abdominal distension, vomiting, severe abdominal pain, and the constipation. These four cardinal symptoms of the obstruction, they cannot be present in case of the partial obstruction, right? Because there's a partial obstruction, so the other segment actually compensates for that. So in case of the partial obstructions, these symptoms cannot be that much pronounced, and this is also called as subacute intestinal obstruction. So particularly if we talk about the acute intussusception, because it's causing the intestinal obstruction, so all of these symptoms can be present, and you can see a basically saucer-shaped lump which is in the concavity towards the umbilicus. You can see whenever you're examining the patient. There are different types of the intussusceptions. There can be ileal, there can be ileocolic, there can be ileocolic, there can be colocolic, and there can be multiple and retrograde, and there can be other causes as well. In case of children, the most common intussusceptions that involve the ileocolic, that means the proximal ileum is actually going into the colon, which is the distal segment. So in children, the most common cause would be ileocolic, but in case of the adults, the most of the common cause is colocolic. So you have to keep these things in your mind about the types of the intussusception. So this was about the causes of the intussusception. So far now we have discussed about the different types of the obstruction. We talk about the dynamic obstruction, and we talk about the adynamic obstruction. The dynamic obstruction, they are the mechanical obstructions, and in case of the adynamic obstruction, there is no mechanical obstruction, but the peristalsis is absent. But in case of the dynamic obstruction, the peristalsis is present. So the dynamic obstruction, we talk about a lot of intraluminal, like the bowel obstruction, food, gallstones, fecal impaction, trichobazoars, phytobazoars. We have already talked about all these things, right? And particularly also the other extramural and intramural causes of the obstruction, like the extramural causes, they include the adhesions in the band, and the intramural causes, they include, the volvulus, the intussusception, the malignant strictures. All of these actually the causes of the intramural obstructions, or intramural dynamic obstructions. So the question is this: how the patient is presenting to you. I've already talked about the signs and symptoms: abdominal pain, swear abdominal pain, which is colicky in nature, abdominal distension, vomiting, and constipation, right? How would you proceed? What are the imaging modalities to see the intestinal obstruction? The x-ray, abdominal x-ray, x-ray erect and supine. In supine, you will only appreciate the dilated gut loops. You can see here, this is the dilated gut loop, which you can appreciate in the supine x-ray. And in case of the erect abdominal x-ray, you can find out the air fluid levels. You can see here, this is supine, this is erect, and in supine you can see the different kinds of dilated loops of this segments of the intestine. And in case of the erect abdomen, you can see the airflow levels. You can see the multiple airflow level that indicates the obstruction. There are other imaging modalities as well. The CT scan is actually very much diagnostic. So it also you can see here that in a CT scan, actually you can point out the segment of the gut which is being dilated in the CT scan. And you can see here there's a large dilated portion with the air fluid level as well. You can see there's a free fluid in the wall within the lumen of the intestine, and there's a small air in the gut. Most of the time there's air in the gut, there's gas in the gut, but actually there's a fluid portion is also there proximal to the obstruction, so you can appreciate the airflow levels. And plus you can see here, this is a dilated portion of the colon, which you can appreciate in the CT scan. Plus ischemia can be, you can pick up the ischemia as well in the CT scan if there is a reduction in the enhancement. So obviously you'll think about the ischemia, and so CT scan is a very much important diagnostic modality to rule out the intestinal obstruction. First the x-ray, and particularly the abdominal x-ray, and particularly the x-ray in a supine and erect position, and then you have to go for the CT scan. So this is particularly again the erect abdomen x-ray, which is showing the multiple air fluid levels. You can see here, but here if you find out the at the portion of the diaphragm, so this is a common air fluid level, and at the portion of the terminal ileum, these two air fluid levels are common. If you find air fluid levels other than these two sides, they will indicate about the obstruction. So you can see here in the CT scan as well. So this was about the imaging modality for the intestinal obstruction. There's another type of the obstruction which is called as a volvulus. Actually, in case of the volvulus, what happens, a segment of the portion or the segment of the intestine is twisted upon the other segment, or twisted upon its own self, right? So it can be congenital or it can be acquired. In case of the congenital volvulus, in case of the children, there can be already a malrotation of the gut. And in case of the malrotation of the gut, there can be They can be volvulus, but sometimes in case of the adults, they can be secondary to adhesions and secondarily to the band formation, and the patient will present again to you with all those. They can be a cecal volvulus, they can be a sigmoid volvulus, they can be a colonic volvulus. So this, the site and the symptoms depends upon the part of the gut segment which is being involved. So most of the time, volvulus is actually involving there can be small bowel volvulus as well, there can be large bowel volvulus as well, but most commonly large bowel volvulus is very much common. You can see here there's the portion of the intestine, and it is being twisted upon its own self, and that twisting will lead to the intestinal obstruction. There's another type of the volvulus which is called as volvulus neonatorum, and this is a congenital volvulus, and it is existing on a malrotated gut. So we know that in the 6th week of the embryological period, there's a rotation of the midgut, right? But what happens that in few children, this rotation it doesn't take place, and that particular entity is called as a malrotation of the gut. So already those babies which are being born with a malrotated gut, in that malrotated gut, volvulus neonatorum is very much common, and it is a surgical emergency. And most of the time, these patients they have failure to thrive. So this is you can see here in this that is already a malrotated gut, but in case of the malrotated gut, this is malrotated, but actually the malrotated gut actually twists upon its own self, and that is called a volvulus neonatorum. There can be sigmoid volvulus, like involving the sigmoid part, and most of the time we know that the mesentery of the sigmoid colon and transverse colon, these are very much long mesenteries. So sometimes the sigmoid segment of the large intestine, it is rotated upon its own axis, so that will lead to the sigmoid volvulus formation. And most of the time, I told you that the acquired causes for the volvulus is adhesion or the band. So whenever there is a band of the adhesion, just close to that adhesion band or over that band of the adhesion, the gut segment is rotated. So you can see here, because the mesocolon is very much large, so that's the cause of the sigmoid volvulus. And there's another condition which is called as a compound volvulus. In sigmoid volvulus or a cecal volvulus or other types, actually the same segment is rotated upon itself. Like the sigmoid colon is rotated upon sigmoid colon, right? And a cecal cecum is rotated upon cecum. But in compound volvulus, one portion of the intestine is rotating on the other portion, right? Like the ileosigmoid or ileocolic, the terminal portion, you can see here, this is the cecum, and this is the terminal ileum which is coming out. So what happens that the terminal ileum is rotated upon the sigmoid colon. So this is called as a compound volvulus. There's a cecum, there's a sigmoid colon, and there's the terminal ileum. So you can see here the terminal ileum is being rotated on the sigmoid colon. So this is called as a compound, and there's also the descending colon. So actually multiple segments of the intestine are rotating or twisting upon their cells. So they call it a compound volvulus. So we talk about the sigmoid and the cecal volvulus. They were single, they're just rotation, there was twisting upon their own cell. But in case of the compound volvulus, there can be ileosigmoid, there can be ileocolic. So there are so many compounds of the gut segment which are being rotated or twisted upon their own self. You can see here this is an ileosigmoid knot. Okay, so if we talk about the clinical features for the volvulus, again, cecal volvulus would be would have the classical features of obstruction, and there can be ischemia, and there can be palpable tympanic swelling as well. And in case of the sigmoid volvulus, because sigmoid is a part of the large intestine, so there would be, I talk about the large and the small intestinal obstructions in my previous slides, that whenever there is a small bowel obstruction, vomiting is more pronounced and abdominal distension is more pronounced, right? And in case of large bowel obstruction, constipation is more pronounced. So in case of the sigmoid volvulus, symptoms of the large bowel obstruction would be present, and there will be distension, constipation, and hiccups as well. You can also so overall the symptoms of the intestinal obstruction, they involve the vomiting, pain and distension, constipation, and obviously the dynamic obstruction. There can be other manifestation as well, because I told you that whenever there is intestinal obstruction, there's a chance of strangulation. The patient would be dehydrated, there would be hypokalemia, and the patient ultimately will develop pyrexia, because there will be peritonitis, and peritonitis will lead to bacteremia. So because of that, there would be pyrexia and hypokalemia. There would be dehydration. There would be generalized abdominal tenderness, and the patient may present with shock as well. And if we particularly talk about the bowel sounds, initially, whenever there's obstruction, initially there is hyper active. You can listen to the hyperactive bowel sounds, right? But with the passage of time, and the obstruction is not actually relieved for a very long time, the peristalsis ceases, and then there would be there would be absence of the bowel sounds. So in the early stages of the obstruction, the bowel sounds would be hyperactive. But with the passage of time and obstruction is not being relieved for a very long time, what happens is that the peristalsis ceases, and then bowel sounds would be absent. So there can be other manifestations. We'll talk about the differential diagnosis of the intestinal obstruction. There can be acute gastroenteritis, there can be inoculant purpura, or there can be rectorectal prolapse. So whenever you're actually performing the digital rectal examination, in case of the rectorectal prolapse, the whole of the rectum would be palpated down along with your finger. But actually, whenever you're doing a DRE and you feel a dilated segment of the loop or the dilated rectum or the sigmoid from the finger, you can also feel a fissure or a dip. Your finger will feel a dip. So that's how you differentiate between these. The imaging modalities, again, the same. The cecal volvulus, the sigmoid volvulus, and the volvulus neonatorum. You can see here this is a malrotated gut, and these are the basically the abdominal x-rays, a dilated portion of the cecum here. Here you can see this is the portion of the cecum, and this is dilated. And the sigmoid volvulus, this is the point of the sigmoid volvulus. And in case of the volvulus neonatorum, you can also see the malrotation of the gut. And other imaging modalities, they include the CT scan. You can also see different types of the air fluid levels. These are the cecal volvulus and sigmoid volvulus. Again, they're a dilated portion of the gut with the air fluid levels. And in volvulus neonatorum, you always find at the malrotated gut segment with the air fluid levels in a CT scan imaging, right? So this was about the different types of the intestinal obstruction and how the patient is coming to you or presenting to you with the signs and symptoms of the obstruction, and how would you differentiate what is the imaging modality. In our next lecture, we will be talking about the treatment modalities for the treatment option, the pharmacological option, initial management of the intestinal obstruction, and also about the different types of the surgical options we have to relieve the intestinal obstruction. So thank you for watching, and keep watching sqadia.com for the next presentation. Thank you.